Okay, this is chapter 16 on heart anatomy, and we're going to discuss the composition of the heart, the location of the heart. We'll describe blood flow through the heart, talk about the heart sounds and valves, list the vessels that supply and drain the heart, and talk about the conduction system of the heart. So the heart sits in the pericardial cavity in the mediastinum, which is located between the pleural cavities in the thoracic cavity. The apex is the pointed end of the heart and rests just above the diaphragm, and the base is the upper flattened portion where the great vessels enter and exit the heart. The precordium is the anterior portion of the chest that overlies the heart. The study of the heart is termed cardiology, and its primary function is to pump blood around the body so that cells can gain nutrients and oxygen in order to sustain, repair, and growth. The adult heart is about the size of a closed fist and weighs approximately 1 pound. The heart has several layers that cover and protect it. The endocardium is the inner layer of the heart which lines the lumen. The myocardium is the cardiac muscle tissue that actually does the pumping action. And the epicardium is essentially a membrane that, along with the parietal pericardium, secretes pericardial fluid. Okay, so the pericardium is like a sac that surrounds the heart, and the sac itself has two layers: the parietal pericardium, which clings to the heart chamber, and the visceral pericardium that clings to the organ itself. And the fibrous pericardium is simply the outside of the parietal pericardium and attaches the pericardial sac to the surrounding structures. The pericardial space is filled with pericardial fluid. Between 10 and 30 ml acts as a lubricant so that the pump can operate without irritating, inflaming, and scarring itself. This is true for almost every internal organ, that it's surrounded by a serous membrane if we're talking about a cavity that's not open to the outside world. And the purpose of the serous membrane is not only to attach the organs to the surrounding structures so they don't twist, buckle, or kink, but also to lubricate the moving organs so that they don't inflame and scar themselves. An inflammation of the pericardial membranes is called pericarditis, and we can pick this up with a stethoscope as a friction rub, and it's the result of a secretion of excess serous fluid which can impede the ability of the heart to pump, and in some cases can lead to a condition, if you bleed into the pericardial sac, called cardiac tamponade, which is usually expressed in the patient as angina pectoris or choked chest, which radiates from the center of the chest outward. The heart is a double pump. The right side of the heart receives blood from the body and pumps it to the lungs, while the left side of the heart receives blood from the lungs and pumps it to the body. So we have two types of circulation: the pulmonary circulation, which is between the heart and the lungs, and the systemic circulation, which is between the heart and the body. So if we look at the systemic circulation, blood from the body returns via the superior and inferior vena cava and the coronary sinus on the back of the heart into the right atrium, which is the one of two upper chambers in the heart called atria. The right atrium is going to send the blood into the right ventricle through the tricuspid valve, which is a one-way valve that only opens into the lower chamber. The right atrium, after it sends the blood into the right ventricle, will then relax and receive more blood. But while this is going on, the pressure in the right ventricle is increasing, and eventually It's going to open the pulmonary semilunar valve and send the blood to the lungs, where it'll pick up oxygen and dump off carbon dioxide, and it'll change from a dark to a bright red, and then it'll return to the left atrium through the pulmonary veins, now completely oxygenated, and then left atrium will send that blood through the bicuspid valve into the left ventricle, which will then begin to increase pressure, shutting the bicuspid valve and eventually opening the aortic semilunar valve, and that sends the blood out to the body. So the systemic circuit would go from left ventricle out to the body all the way back to right atrium, while the pulmonary circulation would go from right ventricle to lungs back to left atrium. Note that the right side of the heart only deals with deoxygenated blood, and the left side of the heart only deals with oxygen-rich blood. The chambers are listed here. The receiving chambers of the heart are the right and left atrium. The right atrium receiving blood from the body, the left atrium receiving blood from the lungs, and the discharging chambers are called the right and left ventricle. Right? The right ventricle discharges blood to the lungs, and the left ventricle discharges blood to the aorta, which leads to the body. The vessels that dump into the right atrium from the body include the superior and inferior vena cava, and the pulmonary, the coronary sinus, which actually drains blood from the heart organ itself. And then the outgoing vessels are the aorta and the pulmonary trunk. Okay, the aorta brings blood out of the heart to the body, and the pulmonary trunk brings blood out of the heart to the lungs. Okay, and this will be clearer once we see a video and a picture of the heart in action. Okay. Important to understand that when we talk about arteries and veins, this is a distinction in terms of the direction of the flow of blood. Arteries always carry blood away from the heart. Veins always carry blood back to the heart. And the color of the blood is going to depend on the circulatory system we're talking about. Okay, in the systemic circulation, the veins carry deoxygenated blood and appear blue from the outside of the body, and the arteries contain oxygenated blood and appear red, while in the pulmonary circulation, the veins carry oxygenated blood and appear red, and the arteries carry deoxygenated blood and appear blue. Okay, so don't automatically think that just because a vessel is blue, it's a vein, or because it's red, it's an artery. Okay. We review the blood flow through the heart. Again, blood that empties into the right atrium comes from the heart itself and the rest of the body. So that's superior and inferior vena cava and coronary sinus. From the right atrium, we flow through tricuspid to right ventricle. Right ventricle begins to exert pressure. That closes the tricuspid valve and eventually opens the pulmonary semilunar. That blood flows through pulmonary trunk to pulmonary arteries to lungs, where the blood picks up oxygen. Pulmonary veins bring that blood back to left atrium. The left atrium then dumps the blood into the left ventricle through the bicuspid valve, and then the left ventricle begins to exert pressure, closing the bicuspid valve and opening the aortic semilunar valve, and the blood goes out to the body. Now, an important point with all of this is that I don't want to get you thinking that just because we've traced the blood from right atrium to right ventricle to lungs back to heart in the left atrium, then to left ventricle, that the sequence of events that moves the blood is going to proceed first with the right side of the heart doing the work, and then the left side of the heart waiting for that work to finish before it begins. The four chambers of the heart, as shown here, are always going to pump together, right? The two upper chambers, the atria, are going to squeeze at the same time. They will send blood into the two lower chambers, the ventricles, which will then squeeze at the same time, and that will shut the valves between the atria and the ventricles, so the blood can't go back in the other direction, and eventually open the semilunar valves on both sides to the pulmonary trunk and the aorta, and the blood will go out. So it's always squeezed together on the top and then squeezed together on the bottom. And after each squeeze, the chambers will go back to relaxing. Okay, so it's squeeze, relax up here, then squeeze, relax down here, and then repeat over and over and over again. The AV valves ensure that blood only flows in one direction through the heart. Okay, the right atrioventricular valve is called the tricuspid because it has three flaps. The left atrioventricular valve is called the bicuspid because it has two flaps. It's sometimes referred to also as the mitral valve because it looks like a bishop's mitre, okay, little hat, as you can see there in the video. You'll notice that the valves themselves are held in place by little tendons called chordae tendineae, and those have a dual role. They ensure that the valves only open in one direction, and they make certain that when the pressure is exerted in the ventricles, that the valves don't flip back into the atria. Okay, so we open only from atria to ventricle, and we don't ever flip back in the other direction. If that were to happen, that's called a prolapse, and that can be heard as a heart murmur by a stethoscope, and often that needs to be surgically repaired. Okay? The semilunar valves also promote one-way flow, but instead of using these chordae tendineae attached to the floors of the ventricles like the AV valves do, they use the fact that they're sort of cup-shaped, and that when they flip back towards the ventricles, they sort of jam into each other, and then they can't continue to move backwards. Okay, so the result is that they produce a seal, and that is under normal circumstances. Sometimes the semilunar valves can get damaged. They can get little deposits on them, and they don't quite close the way they're supposed to, and you can hear that as a heart murmur as well. Okay, all of these things can be either surgically repaired or in some cases replaced in most cases. So that's critical that the blood only flows through the heart in one direction. If this weren't the case, we wouldn't be able to effectively pump blood around the body. The pulmonary semilunar valve is between the right ventricle and the pulmonary trunk, which leads to the pulmonary arteries, and the aortic semilunar is between the left ventricle and the aorta. Okay, and we've talked about the fact that these valves only open in one direction. What controls the way they open and close are simply pressure differences. Okay, when the pressure in the atria is greater than the pressure in the ventricles, the atrioventricular valves, the tricuspid and the bicuspid, will open into the ventricles. When the pressure in the ventricles is greater than the pressure in the aorta and the pulmonary trunk, then the semilunar valves will open up and the blood will flow into the aorta and the pulmonary trunk. The change in pressure in the chambers is the result of those chambers squeezing on the blood that they contain. Okay? You can listen to the heart valves by utilizing a stethoscope, and you can see here that depending on where you put the bell of the stethoscope, you'll pick up different valves. You can pick up the aortic valve by placing the bell of the stethoscope between the fourth and fifth rib on the right side. Okay. You can pick up the pulmonary semilunar valve by placing the scope between the second and third rib on the right side, close to the sternum. You can pick up the bicuspid valve by placing the stethoscope near the apex of the heart, between 5 and 6, and you can pick up the bicuspid by placing the stethoscope near the sternum between ribs 4 and 5 on the right side. Okay, so depending on where where you place the stethoscope, um, you'll be able to pick up different valve sounds, and that lets you determine if the valves are working properly. There's two heart sounds. They're called lub and dub. Okay, lub is sometimes referred to as S1 or sound 1, and dub is referred to as S2 or sound 2. Um, lub is the closing of the atrioventricular valves. It's actually the sound that's heard as the blood bounds off of those valves. Okay, when the ventricles begin to exert pressure, the AV valves will slap shut, and that's what you're hearing. And the second sound, dub, is the closing of the semilunar valves as the blood bounces off of them. Okay. So this is a look at the cardiac cycle.
Ventricular contraction causes the atrioventricular valves to close, which signals the beginning of ventricular systole. The semilunar valves were closed during the previous diastole and remain closed during this period. Continued ventricular contraction increases pressure in the ventricles above the pressure in the aorta and pulmonary trunk, causing the semilunar valves to open. When the ventricles relax and their pressures drop, blood flowing back toward the relaxed ventricles causes the semilunar valves to close, which is the beginning of ventricular diastole. Note that the atrioventricular valves remain closed. When the pressure in the ventricles becomes lower than the pressure in the atrioventricular valves open and blood flows into the relaxed ventricles. This accounts for most of the ventricular filling. The atria then contract and complete the ventricular filling.
So we've talked about the normal flow of blood. Disruption of the normal flow of blood will divert blood from the right to the left heart, and this will result in a reduction in what's called cardiac output. So essentially, this could be brought about by a defect in the walls that separate the four chambers. Those are called septal defects, and they're often the result of improper heart development or improper closure of openings that exist during the time in the womb when you're a fetus. Okay, the pressure gradients that drive the blood through the heart, if the septa are not fully formed, will cause the mixing of unoxygenated and oxygenated blood, and the result is going to be a reduction in cardiac output and sometimes the bluish appearance known as cyanosis. Okay, so often this has to be fixed before the baby's born. We can pick this up with ultrasound, and we can actually do surgery in the womb, which is extremely interesting because surgical procedures in the womb heal with no scars, which is a bonus. Examples of defects that you'll see prior to the birth of the baby: one is called tetralogy of Fallot, where there are four heart defects that occur in a cluster. We see stenosis of the pulmonary valve. We see enlargement of the right ventricle, and we see usually a ventricular septal defect that goes with that. And usually that has to be repaired before before the baby's born, or else the heart is not going to have adequate output to support life. Okay? Blood supply to the heart muscle itself is a result of the coronary circulation. The blood that constantly flows through the heart doesn't nourish the myocardium. The myocardium has its own blood supply that starts with the right and left coronary arteries that branch off the base of the aorta. The left coronary artery has These two main branches, they're the primary source of the blood supply um, for all the myocardium. The left coronary artery has two main branches, the circumflex and the left anterior descending artery. These are the primary sources of blood supply for the left ventricle. If these vessels are blocked, a surgical procedure can reroute the blood around this block, and this is known as coronary bypass. Other procedures that include angioplasty and stenting can also be used to treat the blocking of the coronary arteries. Okay? Again, you have to remember that heart muscle tissue does not repair. So if it dies, it's replaced with scar tissue, and the result is that the heart is weaker from that point on. Okay? So we have to be very careful when we have a myocardial infarction. Normally, coronary blood flow can increase with exercise, but occluded vessels are already maximally dilated, so the person will feel immediate discomfort when they exert themselves. Coronary blood flow is greatest when the myocardium is relaxing, because that reduces the pressure on the right and left coronary arteries, since they run through the little groove that separates the base of the heart from the lower chambers. Okay? So paradoxically, when most of the blood is being pumped to the body, the heart perfusion is at its minimum. Okay? Following a myocardial infarction, levels of aspartate aminotransferase, lactate dehydrogenase, and creatine phosphokinase are elevated, and that's due to the damaged heart muscle tissue releasing those enzymes into the blood. And so you can pick up this damage with a simple blood test. A myocardial infarction is simply a fancy term for a heart attack, and it's the result of loss of blood flow to the myocardium to the point where the tissue is permanently damaged. Okay? An important symptom known as angina, which is essentially pain that radiates through the chest, is the result of cardiac cells needing more oxygen while the oxygen supply is insufficient, and that can result from partially blocked blood vessels in the coronary circulation. Okay? So normally, when we're talking about a myocardial infarction, the pain from that is felt as radiating through the left jaw, neck, and the left arm. All right, and that's an example of what's called referred pain. That's due to the fact that the pain leads from the heart and the pain leads from that side of the body enter the spinal cord at the same location, and they ring on the same pain line in the brain, and the brain has difficult time distinguishing between those two sources. An important point about the heart's ability to pump blood is that the entire organ beats as if it were all connected together, and the reason for that is that it literally is. Okay, cardiac muscle tissue is unusual in that the cells are hooked together by special junctions that are called intercalated discs, which contain both desmosomes, which are like seals between the heart muscle cells, and gap junctions, which are tunnels that connect the cells, and the tunnels allow the flow of current very rapidly through the entire myocardium. So essentially what the heart does is that the heart muscle cells that are able to generate an electrical signal called an action potential most quickly are the ones that set the pace for the heart. And in the heart, that's usually located in a region called the SA or sinoatrial node, which is just under the superior vena cava. And the intrinsic rhythm of the heart at rest is about 75 beats per minute. Okay, cardiac tissue fires cardiac impulses regularly, This autorhythmicity is a unique property of cardiac muscle tissue, but um, it's only the fastest cardiac muscle cells, the cardiomyocytes, that set the pace for the heart. So this is a look at the heart's conduction system.
Action potentials originate in the sinoatrial node and travel across the wall of the atrium from the sinoatrial node to the atrioventricular node. Action potentials pass slowly through the atrioventricular node to give the atria time to contract. They then pass rapidly along the atrioventricular bundle, which extends from the atrioventricular node through the fibrous skeleton into the interventricular septum. The atrioventricular bundle divides into right and left bundle branches, and action potentials descend rapidly to the apex of each ventricle along the bundle branches. Action potentials are carried by the Purkinje fibers from the bundle branches to the ventricular walls. The rapid conduction from the atrioventricular bundle to the ends of the Purkinje fibers allows the ventricular muscle cells to contract in unison, providing a strong contraction.
One of the things that we need to appreciate about this conduction system in the heart is that we can track it using a technique called electrocardiography. Okay, an EKG is simply a tracing that indicates the different parts of the waveform that lead to the ability of the heart to contract as a unit. On a typical waveform with an EKG that comes from electrodes being placed around the heart, you can use as many as 32 electrodes. You can use as few as 3. Um, but they basically surround the heart. Okay. Um, Typical examples for a 3-lead would be one on the leg, one each on the right and the left wrist. Okay. Um, but the idea is that these electrodes can read 3 things about the electrical signal that goes through the heart. They can read the electrical signal's direction, they can read its magnitude, and they can read its speed. Okay, so the typical waveform on an EKG is shown here. The P wave represents atrial depolarization, all right, and the QRS complex, the spike here in the middle, represents both the repolarization of the atria and the depolarization of the ventricles, while the T wave represents the repolarization of the ventricles. So the way that I always tell students to remember this is that you can just think of a rhythmic chant, okay? Depolarize, squeeze, repolarize, relax, depolarize, squeeze, repolarize, relax. First for the atria, then for the ventricles, over and over until you die, okay? Squeeze you can call systole, and relax you can call diastole, okay? So you could rewrite the chant as depolarize systole, repolarize diastole, depolarize systole, repolarize diastole. First for the atria, then for the ventricles, over and over until you die. Okay. There are different intervals in the EKG that are important. The PR interval is the travel time of the cardiac impulse from the atria to the ventricles. Okay. When the PR interval gets too long, either from disease or drugs, or various degrees of heart block can occur. A complete heart block means that the signal can't pass from the atria to the ventricles, and that's an immediate medical emergency. So what I wanted to show you here was an example of how the electrical signal spreads through the heart and the EKG that results from it. So let's start this, and as you can see here, the SA node fires, the wave passes to the AV node, the blood goes from the atria to the ventricles, then we go from the AV node down the Purkinje fibers, down the AV bundle to the right and left bundle branches, and then down up to the apex, and then up the Purkinje fibers. So let's do this in sequence so you can see it. Okay, there is the firing of the SA node. Okay, and then we can bring it down here. Okay, and you could see the atria squeeze. Okay, And now the AV node captures. And notice that the AV valves are open, all right? And the blood is now pouring from the atria to the ventricles, okay? And then the AV node holds the signal for a tenth of a millisecond, and then down we go through the interventricular septum to the apex of the heart, okay? And that passes through a structure known as the bundle of His, which is up here, and the right and left bundle branches, which bring the signal to either side of the heart. And then we're going to go up the Purkinje fibers to the atrioventricular septum, and then the ventricles will squeeze, all right? And then you'll see the final wave, the T wave, okay? So I like this video because it lets you see two things at the same time, right? There's the firing of the AV node, okay? Firing of the AV node. Sorry, firing of the SA node. Captured by the AV node. We send it down the bundle of His to the bundle branches, up the Purkinjes, right? The ventricles squeeze, and then the repolarization wave works its way up, and then we relax, okay? So we'll watch it one more time, all right? So we'll go one more time. SA node fires. We depolarize the atria. They squeeze. AV node captures. We send it down the septum, then up the Purkinjes. The ventricles depolarize and they squeeze. Then the ventricles repolarize and they relax, right? And you can see the waves on the bottom here, P, QRS, and then T wave, okay? So I like that. It's a way to see both things at the same time and understand what you're looking at, all right? I thank you for watching this podcast with me. I'll join you guys in the next podcast. And again, if you have any questions, just shoot me an email, and I'll be happy to respond. Thank you very much.